All right. Carl H. Rush has specialized in policy and workforce development for community health workers since 1996. He has advised community health worker policy initiatives in more than 25 individual states. He was a lead author on the Health Resources and Services Administration and the Social 2007 Community Health Worker National Workforce Study and co-lead for the Community Health Worker Core Consensus or C3 project that went on from 2013 to 2016. Carl completed two national policy studies with the CDC on community health worker certification workforce development strategy. He is a consultant to the National Academy for State Health Policy on their current Community Health Worker Policy Learning Community TA project. He was on a steering committee that became the inaugural board of directors for the National Association of Community Health Workers and has served as a policy consultant to the NACHW under contract. And without further ado, I'll pass it along to you, Carl.
Thank you, Wes. Good morning, everybody, and thank you very much for this invitation. It may surprise you that I haven't really done that much work internally within Texas over the last 15 or 20 years, but I did get started here in San Antonio in this field. You're absolutely right that this is a hot topic right now. There've been a number of webinars nationally particularly on the new opportunities with Medicare. So I'm going to deliver two sections of this presentation. I just wanted to check in quickly. The first section is going to be on Medicaid, but if you would like to pause for some discussion there or have everybody hold their comments and questions to the end, what would be your preference, do you think? I can do it either way.
I think maybe just at the end, and what I can ask the audience is please just type it in if you have something pressing, so
Sure.
you can keep listening. Yeah. Okay.
That sounds great. Okay, well, I will get started here. First off, about Medicaid, and I want to start from the very get-go to say that in most of you are aware, Medicaid and Medicare are very different situations, just in general, and they are very different situations in their support for community health workers. But the first
Hello.
Hello. Hello. And, but the other point is that when we talk about the subject of sustainability, that sustainability is about more than just funding, number one, but that neither Medicaid nor Medicare or the two together will be sufficient to sustain the kind of workforce we want to have for community health workers. And there are a lot of reasons for that. I'm sure you can picture what they are, but we are estimating that for one of these public programs like Medicaid or Medicare, that an employer can only support, or there will only be about 50 to 60% of that CHW's hours will be billable to one of those programs. And there are a lot of reasons for that, mainly, as most of you are well aware, that CHWs need to do a lot of things that other health-related professions don't have to do that are not billable. For example, developing and maintaining relationships with people in the community is essential to what they do, but in and of itself, it's not billable to any funding source, really. So let's just start in with that. Medicaid has been in the picture for quite a few years now, and there are 15 states that have in various forms a state plan amendment covering community health workers. And there are a lot of really interesting developments in that we can get into. I haven't really planned on it, but we can discuss later on how this relates to federally qualified health centers, for example, which are a very special case. And there are a number of states that have come up with some interesting strategies to try to relate to to deal with the dilemmas of the FQHCs. So why this interest? This has been growing for some time, particularly at a high pitch in the last few years. There's the perennial issue that Medicaid in any state is under pressure to control costs or sort of bend the cost curve, if you will, to reduce the rate of growth of Medicaid spending and to improve care to recipients. So that's a given. And you'll see in each of these instances that community health workers are in a unique position to help the state with those issues. So the next one, of course, which we're all very concerned about, and a very welcome new level of interest in health equity and socioeconomic drivers of health or social determinants. And that again is focusing on the unique abilities of CHWs to address them. But really, one of the things that's brought it all into sharp focus was our experience with the pandemic, in which the very communities that were hardest hit by the pandemic were the ones that were hardest to effectively reach. And again, community health workers have been shown to be uniquely suited to work with both prevention and immunization uptake and contact tracing, all those things that deal with a pandemic with the populations that are most at risk, because they're vulnerable populations, both clinically and socioeconomically, that were hardest hit by that pandemic. And then there's a larger sort of seismic shift in the way people are thinking about healthcare, not just with Medicaid or Medicare, but just in general. And this is a kind of unique recognition we're coming to right now, in that we're shifting healthcare from a largely transactional system. I'll explain that in a sec. A transactional system to a relationship-based system. If we're going to make progress, particularly with the most vulnerable populations, that relationship will be crucial. So by transactional, I mean that when we experience a need for healthcare in some form, we seek out a provider, we receive a service, and somebody, either we ourselves or another party, will pay for that, and we walk away. And so I've made an analogy to like a vending machine, that we walk up, we put in our money, or more likely our card, and we receive a service and we walk away. And I couldn't resist the irony of making it a bacon vending machine. But but what we're seeing now is a shift to more relationship-based care, where we're connecting with the entire environment around the individual. So the patient in a family context, and the environment around them, in terms of the old original meaning of social network, where people have resources in the community, family, friends, neighbors, and so forth, and really building the care for that individual in that holistic environment. And it turns out that when we're talking about the Medicaid population in particular, that community health workers are the experts in establishing trust and communication with low-income and marginalized or disenfranchised populations. And so if we didn't have CHWs already, we would have had to invent them in order to make this work. And we're learning that CHWs are the factor that enables the system, particularly under Medicaid, to do what it's supposed to do. And so trust and communication, we have all heard and seen examples of the many factors that create let's say, a less than ideal level of trust between providers and patients. That is clearly there. I don't need to go into those details, but the communication can really just be the basic mechanics. How many times have you run into, or you may be a Medicaid provider who sees a notation in a patient's chart to the effect of lost to follow-up? And if you're working in a relationship-based system, that's not okay. You can't lose people. If you're a medical home or an accountable care organization, you are not fulfilling your responsibilities if you lose people. And that, of course, makes it much harder to serve folks adequately. So what most states have done, yes, there are waivers out there, 1115 waivers. We had some very interesting experiments with waivers in the disrupt waivers here in Texas, including one in my hometown in San Antonio, in which, and the program is still going on, in which CHWs were assigned to census tracts with high risk factors in health, and they were responsible for mobilizing the residents of that neighborhood to decide what their health priorities were and develop strategies to address them. Which was a lot of people hear about that and they said, Medicaid paid for that, and in Texas, you got to be kidding. So at any rate, there's opportunities in waivers, but most of the states are using the state plan amendment route. So very briefly, what some of you are very familiar with this, I'm sure, but I don't know, for example, for sure whether Texas would require enabling legislation if the state were motivated um, to create a state plan amendment. But oftentimes, legislatively, it's easiest to pass a bill that you might call a study bill to establish a work group or task force to create the recommendations. And it in a number of states, these study bills around Medicaid have also included consideration of certification, which Texas has had since the early 2000s. But one of the lessons learned is if you're going to adopt legislation or propose legislation in this area, don't put a lot of the detailed proposals that you would like to address into that legislation, because when it goes through the legislative meat grinder, it will there'll be a lot of ways that the legislation can be imperiled um, if the legislators get into discussing those details. Um, it is an article of faith in the community health worker world. Nothing about us without us is the mantra that um, that key officials support a strong role, indeed a leadership role for CHWs in program decisions around Medicaid before this work group is formed. We've had some states that have tried to hustle this through with minimal participation from CHWs. And we'll come back to what kind of capacity building is necessary if CHWs are going to be involved in this. And it often in most states requires the plan for the state plan amendment has to be approved by top officials before it can be forwarded to CMS. The good news about all this is at least that CMS has been very hospitable and collegial in helping states get their plans approved. In one case, New York, which got a plan approved last year, they originally came up with a plan that was only going to serve pregnant and postpartum women. And in their negotiation with CMS, they were persuaded to open it to all categories of eligibility under Medicaid. So that was a very interesting development. But CMS is at least currently is very much on our side. So relationships that are important in pursuing a state plan amendment, and I'll go into a couple of examples of the way the state plan amendments look most commonly these days, is you are going to need to develop strong relationships to make this happen. Obviously, that um, it's really important to keep in mind the idea we're learning is not so much to come to Medicaid hat in hand saying we need your help to sustain a CHW workforce. It's not their job to do that. Indeed, it's not their job to sustain any particular workforce. Their job is to underwrite healthcare for low income individuals, and how they get there is part of the design, but it's not their mission to support the workforce itself. A lot of folks have been leaning on the issue of financial return on investment, and it is true that potentially the states can realize net savings from paying for CHWs. But if you lean on that too heavily in talking with state officials, that can be a trap. And we found this to be true over many experiences, that there's never enough evidence. No matter how many studies you show them from elsewhere in the country, they say, well, that's true there. We need proof that it'll work here. And no matter what, some decision makers will still be skeptical. Some of my colleagues, I don't have in my bio usually, that we actually had a policy center on CHWs under the UT School of Public Health for about 6 or 7 years. And we only closed it down because my two colleagues who were actually employed by UT moved to other institutions. But one of the first things we did was a study for DSHS on policies around community health workers. And we learned that, at that time at least, that the Health and Human Services Commission believed that just adding community health workers as a provider type under Medicaid was going to cost the state over $1 million, just adding them to the system as a provider type, the mechanics of that. And I certainly thought to myself, if my IT people told me that, I would fire them. But at any rate, there are always some people in any state who are skeptical, and it may take a long time, and some of them, to prepare. The good news in this case as well is that Medicaid and other state agencies have ongoing priorities and challenges, problems they've been trying to solve for some time, that community health workers can help them with. One example we see in a lot of states is the issue in Medicaid of member engagement. The fact that people are enrolled in Medicaid, they may be assigned to a primary care provider and never go to see them. And the rate of assigned but not seen can be as high as 30 or 40%. And a lot of people, including managed care plans and, of course, the Medicaid program itself, are very concerned about that. So what we're learning, and this is working very well in states like Pennsylvania, is learning what they care about and focusing on that, and become a resource to them and addressing problems they already know they have. And you may all, or many of you may realize this, but this comes as a surprise to some folks in some states. And among the folks who may be allies and champions may include, and this is part of my early experience on this, Medicaid managed care organizations would like the idea generally, and indeed some of them in almost every state are doing stuff on their own, employing CHWs or paying for them as an administrative expense because it makes sense to them business wise. And so you all may have some examples of that to share. But influential providers, there's nothing like a testimonial from a provider that says, I haven't been able to do this with my patients until we got a community health worker, and et cetera, et cetera. And she or he makes me a better physician. So I mentioned earlier that it's really important for community health workers themselves to be involved in policy decisions around Medicaid and designing a state plan amendment. And this is often described as in most states, as a covered service or a new benefit. And one of the reasons for making sure that CHWs are involved is these decisions can directly affect and either enhance or impede the work of the CHWs themselves. And so they need to be involved in these decisions and others, but the ones that jump out what services will be covered. I'm going to give you an example running through real quickly what seems to be a pattern emerging in the covered services. But the lesson has been in general that states are broadening the definition of the services or activities that CHWs can conduct because CHWs need that flexibility to be able to do whatever it takes to help those recipients. What qualifications will be required? CMS, uh, it's a moot point in Texas, obviously, because we have certification, uh, but CMS does not require that a state have certification. And so some states have been kind of twisting themselves into pretzels, trying to figure out how to make that happen without calling it certification. But the qualifications CHWs need to have a say in that and what it looks like. Um, how much time? Most states have a limit to the number of billable hours that can be devoted to any one recipient in the area of CHW activities or services, uh, per day, per month, per year, et cetera. There are only a couple, Rhode Island being a notable example. They decided that the bureaucracy involved in tracking numbers of hours, et cetera, were not really worth it. And if there were some outliers who were using a lot of CHW services, they could be looked into individually. What will be the hourly rate of pay? I think most, if not all of you, are, of course, interested in CHWs earning a living wage, and that is a part of many campaigns in multiple states. That is important, not just in terms of equity and social justice issues, but to reduce the turnover that people may not be able to stay in their jobs because they're feeding their family. So, but the other point about the billing rate has to cover things like supervision and time spent in relationship building, travel time, things like that that are not separately billable. So the indirect that's built into this rate needs to be realistic, and there has been a fair amount of work done on that. Uh, some states have limited what settings CHWs may provide uh, billable services. And there are different reasons for proposing limitations. In some cases, clinicians are nervous about uh, losing control over someone who's out in the community most of the time. We hear that a lot. How can we be sure they're doing things right? That can be worked out, but the point is that there, in other cases, there are clinicians who don't want CHWs competing to provide services in a clinical setting. So they don't want them to be helping people in a clinical setting. The best state plan amendments allow for virtually any setting, but it can be a serious limitation on how CHWs do their job. I don't have time to get into details on this, but uh, there are different standards for who may order or recommend or supervise the activities of CHWs. And the CHWs need to have a say in what that looks like. There are different regulations allowing for funding of these kinds of services. And in the most popular, I would say, regulation is the preventive services rule, which simply says that a clinical provider must recommend preventive services by CHWs. And then lastly, and this is really a big one. In most states, a large percentage, if not a majority of community health workers are employed by community-based organizations. Okay, and it has proven to be a challenge to integrate CBOs into this, to allow CBOs to either partner with another billing provider or to bill uh, to Medicaid or a managed care organization directly. And particularly for smaller CBOs, the administrative burden is really challenging. So there are ways that some states are trying to work through that, and we can talk about that kind of stuff later on if you want. So I'm just going to throw out one example. Um, I worked with Rhode Island, have been working with them for the last several years, and their state plan amendment is a good example of the way the most of the current states are shaping their plan. It relies on the Medicaid Preventive Services Rule, which I just mentioned. In their case, it's a fee-for-service carve-out. They are a managed care state, but they have bypassed the managed care organizations entirely. Claims are submitted to the Administrative Services organization that processes Medicaid claims. And this means that any organization can in effect become a, in quotes, Medicaid provider and submit claims for CHW services. And this includes organizations that already bill Medicaid for other things. It also means that the federally qualified health centers can submit claims outside of their prospective payment system. So this is somewhat, oh dear, typo. Oh well. Um, they use a service code for case management, which is part of the HCPCS system. Most other states use a CPT code, a family of codes 98960, 1 and 2. And this is true even though the range of services covered is much more than health education. In other words, CMS doesn't mind if you use a health education billing code. And this is mainly for simplicity. They don't want people to have to figure out which billing code to use, in other words. In the case of Rhode Island, it was initiated by the governor and former Governor Raimondo, who is now in the cabinet. And the budget proposal prepared by her staff indicated that CHW payment under Medicaid would result in a net saving to the state. And so that's how they got started. It certainly helps to have the governor's support, but they used what, and this is at their own volition here, they used an innovative definition of medical necessity. Medicaid will only pay for medically necessary services. And so it does include a bunch of things related to social determinants or indicators of barriers to access, or, and this is very groundbreaking, the recipient's own self-declaration, I need the help of a CHW. Okay, so, and I'm realizing I'm running way over time here. So, the services covered are in 3 buckets in Rhode Island, and this is similar to what most other states are doing: health promotion and coaching, health education and training. Some states allow health education for individuals as well as groups, and health system navigation resource coordination. And this covers a wide range of things that CHWs can potentially do for recipients. And so this just illustrates the range of things, and most of the recent state plan amendments have followed this general pattern. Some of the things that contributed to their success, of course, their state health department had done a lot of their pioneering work under their health equity and prevention units. The governor's office was interested. They were able to do all this without having legislation enabling the process. And the Medicaid office team was extraordinarily supportive. They were willing to take some chances, and CMS supported the chances that they were taking. There were several initiating pre-existing initiatives that leaned heavily on community health workers, and so that added to their base of support. And they are, as I said, a managed care state, and theirs in particular, it's a very small state, so they're generally statewide health plans that they are but they've been doing stuff with community health workers for many years. And they have already had, as Texas does, they already had certification, which helped them with credibility with providers. So Texas, as you all know, has really not done this, and has kind of, and this is my personal opinion, has dragged their feet on this for some time. I was around for the original legislation in 1999 and 2001. It was very clear from talking to legislators that their intent was to lead to Medicaid payment for community health workers. It did not happen. However, most recently, and most of you probably aware of this, there was a bill passed last year, um, which passed in both houses by large majorities, and Governor Abbott signed it very quickly. And what it does follow a regulation covering Medicaid health plans that was effective in 2017, and it allows those health plans to count certain expenditures on quality improvement in their total claims cost. In other words, part of their cost of care, rather than being counted as administrative or other, um, in calculating their medical loss ratio, which in most states has to be at least 85% of their premium revenues being spent on actual care. And we have heard specifically from CMS that this is an opportunity to encourage health plans to pay for CHW services. I described this last year in a presentation to folks in Florida, and they are also in a situation that they believe Medicaid will pay for CHWs when pigs fly. But they thought maybe this was a way, and it's obvious that it was easy to get passed because it did not mean any additional spending by the state. It was an incentive rather than a mandate, and so yeah, sure, go ahead and do it. Um, in relation to preparing or building capacity for CHWs to engage in this policy process, um, we have been doing a series of 2-hour webinars called Medicaid 101, and that is available preferably to statewide groups of CHWs, and it's proving to be pretty popular. We've done it in 7 or 8 states so far, and about to do several more. So, and that will be, it may be through different auspices in the future, but that's there. So, moving on to Medicare. Medicare coverage for CHW is part of Part B, which is basically physician services, health related. And it's a section that was added to their physician fee schedule beginning this year, dealing with health related social needs. And so this was effective the 1st of January. Here's the citation. We give you a page number because the full thing is like 900 pages, but this is only a small part of it. And the main thing we're going to focus on today is community health integration services. There are also social determinants risk assessments and principal illness navigation services that are also relevant. We don't really have time to get into those. And there is a very useful, you'll be getting copies of these slides. So you can go to this link. There is a primer that was just published last month, the beginning of some further, there will be more educational guidance materials coming out, but I recommend that to you as a further reference. The basic provisions in community health integration is that they can cover a wide range of activities. I'll show you that on the next slide. They can be not just by CHWs, but what they call auxiliary personnel, which would be generally non-clinical providers. And it must be, unlike Medicaid, it must be considered incident to clinical care. So it must be ordered by somebody who's providing ongoing clinical care to that recipient. And it must be determined by that provider that there are health-related social needs that are hampering their ability to diagnose and treat that individual. So that's the general language. It's much more clinically linked than Medicaid. So it must be ordered by a billing provider. That's somebody who's already billing Medicare for services to that individual during what they term an initiating visit. And that provider also provides general supervision. Now, an um, initiating visit must be coded as what they call evaluation and management visit. Um, and that includes annual wellness visits, which must be provided to all Medicare recipients. Unfortunately, that does not include that the individual must be under the care of that provider before the CHW services can be ordered. So it won't pay for services prior to that individual being engaged with a Medicare clinical provider. And that's a very important limitation we need to be aware of. Only one provider can bill for CHW services to that patient. And importantly, CMS is encouraging providers to partner with CBOs, but unlike Medicaid, CBOs cannot bill Medicare directly. Okay, so that's the basic core of what it's about, and we can get into more detail. This is a really useful table, but it shows you that it can be used to cover a whole lot of different things, but it has to be for somebody under the care of a clinical provider. Billing, interesting. There's no limit on the hours that can be claimed. The rates that they are offering are generally higher than the rates that Medicaid is paying in various states. The highest rate that Medicaid is paying is, I think, $66 an hour equivalent in South Dakota, of all places. But the codes are in this primer that I mentioned on the previous slide. And they are adjusted by the state economy, if you will. And the claims are not submitted for each individual unit of service, but on a monthly basis for all the services performed in that month. Services provided in a facility, or facility-based care, they call it. The rates are somewhat lower. The FQHCs have a flat fee, and this is again a HCPCS code, a separate one for them. They do require patient consent, unlike Medicaid in I think almost all cases in all states. However, they're flexible, so it doesn't need to be the same sort of consenting to treatment paperwork that is required in other cases. But the consent can be verbal as long as it's documented. And then this is true for all providers generally, that for most individuals, claims are submitted to the Medicare third-party administrator, except for individuals covered by a Medicare Advantage plan. Okay, the claims are submitted to that plan if they're covered by one. And then the charges not reimbursed by Medicare, authorized charges, can be billed to a Medicare supplement plan if they have one, or to Medicaid in the case of dual eligibles. So just to review real quickly, most Medicare recipients have some other source of coverage. A very small percentage only have original Medicare, but private insurance covers a large percentage of recipients of Medigap and Medicare Advantage. Those who are eligible for both Medicaid and Medicare are a special case, and at some point we can get into that, what the implications of that are. But dual eligibles account for nationally about 14% of Medicaid eligibles and about 20% of Medicare eligibles. So it's a sizable number, and these are clearly folks who may benefit potentially the most from CHW's assistance. But Medicare is their primary insurance coverage. Some of the short-term issues we're dealing with, there is a copay requirement, and a lot of people got their hair on fire about this when it first came up. It is a legitimate concern, but the picture is not as dire as a lot of people realize because, first of all, it is an issue that providers are not permitted to waive those copays. But Medicare Supplement and Medicare Advantage plans um, generally cover that cost sharing. And for dual eligibles, Medicaid is in any state is required to cover those copays for dual eligibles, but states may object to that. We don't know whether they will or not. So the percentage of people, it may only be somewhere like 5% of people who have original Medicare only with nothing else. So it is going to require some attention, but it's not going to be an earth-shattering crisis. Since this is a federal-only program, there was a challenge for CMS in defining what qualifications would be required for Medicare for CHWs under Medicare. If they are certified by the state, that's fine. If the state has training standards but not actual certification, that's okay. If there are no state standards at all, then any completion of any organized training that follows the C3 recommendations will be acceptable. The billing provider just has to attest that the CHW that they're employing has completed such a training. So the relationships to access Medicare are different. There needs to be a lot of communication with major providers. Again, this is Part B. Hospitals are mostly paid by Part A, but they may have affiliated medical groups who may be involved. Providers will be responsible for building, but they may partner, and they are encouraged to partner with CBOs. And you will need to be, if you're not already, talking to the dual eligible program staff in the Health and Human Services Commission about how they're going to respond to this. And it is very important because Texas has multiple markets for Medicare insurers and as they do for Medicaid, but the private insurers need to be aware and assisted in making these connections. So these are all really important. Some of the plans that market in Texas may actually be national plans. Some may be localized, independent, and localized to Texas. There was a webinar. There's a link to this webinar, which will be in the slides for you. And that can give you a more detailed briefing. It's an hour-long webinar. And there's, of course, my email. And then I've included a slide with a bunch of other resources about Medicaid and Medicare for your use. And I commend those to you as a beginning point for further study. There's an employer level financial sustainability toolkit, which is really excellent. And I recommend that to you. Some stuff from California about how they're approaching Medicaid, and then Medicare coordination. And then the primer that I mentioned on an earlier slide is also on this one. So that will do it for me. I apologize. I ran a few minutes over, but do we have, Wes, do we have questions in chat that we should respond to from earlier?
No direct questions.
Okay.
Rosalie had made a couple of comments.
Uh-huh.
Sorry. I'll read the comments and Carl, get to your question. Rosalie had said, in the past, the Texas state legislature I believe, hasn't wanted to consider an SPA because the unknowns related to budget impact. That's why they leaned on quality improvement. And HB 1575 is a limited experiment on reimbursement under Medicaid.
Yeah. That's an understandable concern on the legislature's part. I will say that implementation is not a tidal wave. It's a trickle at first. There is time to get a handle on it. Minnesota had the first state plan amendment in 2008, and 6 years later, their total claims were less than, for the statewide, total claims were less than $100,000. 6 years after they implemented their SPA. So, and the other states are seeing also, it is not happening rapidly. It takes time to roll out. Some other states like Oklahoma is talking about a small scale pilot first. There are a lot of unknowns. And I think the point is there's a legitimate case to say that in the long term, there will be significant offsetting cost savings. So it's a complicated calculation, but other states are, and there are probably another half dozen states that are planning to introduce a SPA in the next within the next year, and they're not all crazy. Okay, so it's the impact, and we'll have more data on impact within the next year or so, but the budgetary impact in the first several years is very modest.
All right. And then, Kara, you had your hand raised.
I did.
No, Kara.
Kara, so not Carl.
Oh, okay.
It's Kara, which is
Alright,
fine.
good.
It doesn't matter either way. Carl, I've had my eye on you for a while and I love the work that you're doing. I just sent you a message on LinkedIn. I'd love to have a side conversation, and thank you for telling us about some of the barriers as well as the information you shared right now. I, I have found with other Medicare codes that are kind of new, there's a lot of anticipation and excitement around those. One example was that LCSWs are now able to bill for health and behavior codes around Medicare. And we saw this coming for a year before it actually happened. I haven't seen the same kind of murmuring and anticipation for these codes. Can you tell me why you think that is? Is it because of the things that you brought up earlier in the slides as challenges, or is there something else?
I think it is largely those challenges, but there are places now where in other parts of the country where there is just a lot of buzz. There is a lot of buzz, and some folks that I'm working with in Pennsylvania, a provider organization is complaining, or their compliance officer is complaining that they haven't gotten more guidance because they want to start billing Medicare, but they don't believe they've received sufficient guidance from CMS to do that. And so that's a novel problem that I think a lot of people are holding back because they don't know what it's going to look like. This is true for Medicaid as well, that a lot of folks don't know what it looks like to bill for services under a healthcare financing program like Medicaid or Medicare for non-clinical providers.
Yeah.
And so it's there are other barriers we can talk about, but
Sure.
but it is because I think one of the reasons that it has not been the buzz has not been as active as most people would anticipate is that the billing providers are so heavily involved and they don't really understand it. And so the early experience over the first year or so is going to be really telling. What are people actually finding out?
Well, I
Because
think, yeah, it's going to be a slow uptake because people don't know, right?
Right,
Ridiculously slower than what you've mentioned in others. And And I continue to be challenged by like this reality of like it's a slow uptake. And it takes a long time to see the financial savings and impact and results, but yet everybody wants you to show in a very short time, like how are you making an impact? So there's
Yeah. Well, I think
dichotomy.
the key to it again is pointing to the other outcomes, the other potential beneficial outcomes,
Yeah.
and not leaning on cost savings, and being realistic and saying we may
Yeah.
not see any certainly net savings for the first 3 years or more,
Yeah.
and but that the outcomes are worth, as my mentor used to say, the juice is worth the squeeze. So
Yeah. I have a lot more questions, a lot to say, but I see Heidi wants to say something. So I'll stop and
sure, yeah,
maybe you and I can have a one-on-one
yeah,
later.
thank you.
Good morning. Thank you, Carl, for being with us this morning and sharing your expertise. Really appreciate the insight into kind of some of the policy and funding mechanisms. One of the questions we've gotten here, and I wonder your thoughts and how this might have played out in other states, is the reimbursement rate. So looking at, what's needed for sustainability of the CHW programs. And there was that great study that came out nationally looking at Medicaid reimbursement rates for sustainability across states. And the Texas rate, I feel like was like 58 or something dollars an hour. But physician providers reimbursements under Medicaid are evidently somewhere in the 30s, 35-ish dollars or $38 in Texas. How do you navigate that? Is there any precedent in other states of the rates of Medicaid are just so low when you look at sustainability of programs? How do we make that make sense?
Well, I mean, that is a rate paid to an individual clinical provider for a unit of service. And of course, everybody complains about Medicaid reimbursement rates being too low.
Right.
And there are, in some of the states that I'm familiar with, the CHW rates, I think Kansas started out at something like $16 an hour. It was ridiculous. Louisiana's at 32. Recognizing the degree of indirect cost that has to cover, it's really pretty ridiculous. But some of the states have acknowledged that they didn't have anything to go on when they set their rates, and they did a relative value calculation of, I think it was 50% or 75% of what a physician would be paid for that same service.
Interesting. Okay.
Yeah. And part of the problem, of course, most states have only one billing code. So the claims data will not give them any information on what CHWs are actually doing. Okay, so
Interesting.
yeah, so they have to dig into chart reviews and stuff like that to find out what is actually making the difference. What is it that CHWs are doing that seems to be most beneficial? Okay, so yeah. Anyway, that's
Thank you.
another long conversation.
Yes, but thank you for the short answer.
Well, that marks the hour. I know thank you so much, Carl, for presenting, and we'll be sure to share out the slides to the group. I appreciate, especially at the end, those resources to have, because these conversations are great to have, but it's good to have that background information for those of us who aren't
Right.
as involved in the weeds. Thank you. Just so everyone knows, next month our next networking session will be on value-based care. And broadly speaking, this similar theme. And yeah, so stay tuned, everyone. And thank you all. We'll put this up on the YouTube channel. And if you aren't, please join Mighty Networks and follow our LinkedIn page for more information. And I hope everyone has a good Thursday. Thank you.
Great. Thanks, y'all.